Hello, everyone. My name is Olatoyosi Odenike, and I am from the University of Chicago. I have been charged with discussing today the issue of what are the key considerations in the management of MPN accelerated phase disease. So to put this in context, I'd like to remind us that MPN accelerated phase disease refers to individuals who have a pre-existing Philadelphia chromosome negative myeloproliferative neoplasm and develop increase in blasts in the range of 10% or greater in the peripheral blood or bone marrow. Those individuals represent a group of patients with relatively short survival in the less than 2-year range. And this therefore represents patients in whom this is a call to action in terms of offering them a specific therapeutic intervention. I favor offering the option for therapy to as many patients as possible, since survival is very short when a supportive care only approach is adopted. I also assess fairly early on whether the patient will be a candidate for an intensive AML induction chemotherapy type approach versus a less intensive approach. Because allogeneic stem cell transplant is the only approach shown to have the potential to produce durable remissions, I prospectively HLA type my patients and start looking into donor options as soon as the diagnosis is made. We are in the era of significant advances having been made in next generation sequencing technologies. We are also starting to understand a great deal about the molecular pathophysiology of these diseases. And therefore, I perform next generation sequencing analysis on the blast diagnosis to evaluate for potential actionable mutations. In many patients, particularly those who develop MPN accelerated phase disease from a background of myelofibrosis, which is the majority of patients, a peripheral blood sample is generally adequate in performing such an analysis because the bone marrow is frequently inaspirable. I strongly favor enrollment in a clinical trial wherever possible. There is no standard approach to the management of these group of patients, and we have a lot to learn. Outcomes are still far from what we would like, and therefore clinical trial enrollment is strongly encouraged. I tailor therapy whenever possible if there's an actionable mutation for which there's a targeted therapeutic approach. So for example, for IDH1 and 2 mutant disease, I favor a clinical trial that would allow access to an IDH1 or IDH2 inhibitor, either as a single agent or in combination with other agents, and for fit patients in combination with chemotherapy. For TP53 mutant disease, since that group of patients represents a traditionally relatively chemo-resistant group of patients, again, I strongly favor clinical trial enrollment In the absence of a trial, I am inclined to favor a hypomethylating agent-based approach over a 7+3 intensive induction approach from a risk-benefit standpoint, especially in older patients who are less fit. For those patients with other mutations who are fit for transplantation and whom a donor is readily available, intensive chemotherapy is reasonable if the patient is willing. For others who may not be willing or able to tolerate intensive chemotherapy, a hypomethylating agent-based approach is reasonable in those instances. There are no randomized trials comparing an intensive approach to a less intensive hypomethylating agent-based approach, but response rates in retrospective series seem, relatively equivalent. For those who do undergo intensive chemotherapy, it is important to stress that remission durations are relatively short. So it is very important to be ready to move forward with an allogeneic stem cell transplant. And in fact, most series that have looked at this carefully demonstrate that the relative benefits of an intensive chemotherapeutic approach are limited to those who are able to proceed with an allogeneic stem cell transplant. Therefore, for fit patients without actionable mutations who are able to tolerate intensive therapy, I would only proceed with an intensive chemotherapeutic approach if I knew that they would be able to then move forward with an allogeneic stem cell transplant. Otherwise, I would pursue an HMA-based strategy, preferably on a clinical trial.